gets very tricky.
But what we're seeing, the behaviors that we're seeing in shelter, I mean, clearly there's some stuff going on with a number of the children that are under our care. So what you think about that?
Well, I've got another curveball I'll throw you in a minute. So I think we're hearing heterogeneous approaches. Generally, a consensus should be done. Sometimes done not as often or as intensively as we like. Better second level screen if you just ask, are you safe? Maybe we're missing things. Have we got the right supports in place for someone who discloses IPV in a doctor's office or in a housing? Have you got somewhere where you think you can send them to get connected? Okay. Now, as you develop your program, you probably need to get these listed so that everyone knows what are the resources out there. Because I've worked in Calgary for 30 years. They're agencies I know about, I've never heard about. You hear, Delta House or whatever. Oh, that's the detox for alcoholics who don't have this, that, and the other. It's really helpful to have a general list, and that could be actually an outcome from what you're doing here. Get a referral system. What about for someone in housing that you kind of find they were tested with HIV and they're rolled into your housing and no one's ever managed them? Have you got a system to refer to the HIV programs? Do you know who to phone? Yes? No? Maybe? I mean, probably, if you're asking about it, you do need a list. Dr. X will see mainly gay males. Dr. Y is really interested in women who are pregnant or may become pregnant. Just that you have a referral system in place. Because that's part of when you ask about these things, you need to know what to do with it. Yes?
So I just want to share a little commercial. The Leinster County Homeless Services Coalition is putting together a resource directory. And we could easily expand it to include everybody. So if anybody has interest in getting their agency listed, contact me at St. Paul Center, Tracy at St. Paul Center, and I would love to include you because it would be valuable for all of us to use that as a reference tool.
Actually, that's great because you're piggybacking on something someone else is already doing. And that's efficient use of resources and dissemination because they'll do half the work for you. Okay, so we've got a referral, we think, for IPV, we've got a referral for HIV diagnosis. What about unstable housing for the HIV or the IPV? If you're in an abuse clinic, you seem to have an overlapping program, but are there good systems in place for housing referrals? Like if Dr. X sees someone that's happened, oh my God, I can't send this person home. You've got a referral? Is your program just women? Okay, what about, I mean, no, you've got...
Housing, permanent housing is just women, but when you're dealing with victims of domestic violence, it's men, women, and children.
Okay. I mean, some of the nastiest stuff that I've seen has gone on in the MSM community. And, we all think because we've been culturally programmed to think of women being abused by men, there's other bad stuff goes on. And you just need to have that when you generate your list. Make sure you've got a list for the gay male who's being abused.
Yeah.
Okay. So we've talked about screening. We've talked about support. Most people in this room seem fairly comfortable asking at a broad level, are you safe? Are you? Is there any other resources that you think we need to look at or you need to help you address this endemic of homeless housing, IPV, HIV stigma? Yes?
I'm sorry to keep harping on this, but what I've heard, knowing nothing about it, is that sometimes people they will ask about IPV because if there's IPV, like they're in a homeless shelter. They ask about IPV because of IPV, they immediately refer to people not safe. That's the why unit. But they're nervous about asking about HIV. So am I right about that? Is that a thing?
Yes.
I was just gonna say, from like the data side, I'm with CARES, so we sort of look at the data on the community side. I will say that, you know, we expect a certain amount of missing data, but that missing rate is typically higher for HIV than any of the other health conditions. And I think it's a mix of maybe some hesitancy to ask or not, you know, knowing why it's important to ask, and also that discomfort with disclosure, so people will just refuse. So I think, yeah, there's a few things sort of going on.
I think to improve people's comfort about HIV, you need to get back to the theme from over there. HIV today, if you take the damn pills, is really easy to manage. That's part of the messaging that we need to do. I mean, for those in care, it's unbelievable how sick people can be, and you can return to full productive life. Yes?
What we've experienced at the HIV clinic is that because our patients feel so safe, they can talk about anything.
Which is good.
Yeah, they are accepted unconditionally. They see the clinic as a home away from home in many instances, because what happens outside of our clinic, in most cases, is that person not wanting to disclose and feeling very guarded and, you know, developing pockets of support, but universally, our patients are still feeling very reluctant. And I encourage that, you know, if you don't have to tell anybody anything, on the job or any place you go, and that seems to keep them safer. So I know for them, coming to our clinic is a safe and healthy part of their world, because they are totally accepted and can talk about anything, and they need to do that. So it's good that we have those safe havens.
Yeah, very important. Keeps the stigma down,
Yeah.
at least locally. Maybe not in the external world, but there is stupid people living
Yeah.
with people. So I think we made headway on that. So, are there any real barriers for us asking? Is it, do we need, asking about IPV, do we need some sort of training, or do we need pamphlets? Or is it the bosses don't allocate time because someone wants to ask about sex when we all know they're having it, not telling us? You know, are there any barriers that you need to address? Because this is actually a good time to get group think if you've got barriers. Yep.
I would say one of the biggest barriers I noticed was, like everybody said, they don't necessarily have a single screen, rather a question that's on the assessment. That's correct. And what I've seen a lot of times is, you know, it's almost like an interrogation. Like, it's like, you know, if you go to your primary care doctor, do you feel safe at home? Like, and you follow up the question like that. It's not really putting them in the right frame of mind to even allow them to be open with us. Because at that point, they're like, yes, no, yes, yeah, I didn't have that kid yet. You know, it's routine at that point.
So it needs to be part of care rather than a drop-down box.
Yes.
I couldn't agree with you more. I mean, I love clean data. I've got OCD about my clean data. But I don't want it ever to come up well, the person walks in and John will be upset if I haven't ticked this box. It's whenever, and sometimes it takes 6 months or a year before you feel comfortable. They'll cough up the real truth and you'll know what's going on. So the barrier may be you can't do it immediately. It could be, yes?
A barrier that I run into sometimes is time. That we do an annual visit with our patients every year. For every patient in the clinic, we try to when they show up. And the patient gets 15 minutes with a case manager, 15 minutes with a nurse, a half hour with a doctor. And so in 15 minutes, I have to ask the patient about their housing, their insurance, their income, their dependents, their substance use, their mental health, their disclosure, their emergency contact, and domestic violence. And if anyone says yes to that, we're going to run out of time.
That's a disincentive. And you know the difficult thing as well is you have to get the right answer. You've got to make them not feel rushed. And that's a terribly difficult skill. To look relaxed, so you think, come on, I've got 6 patients waiting. Cough up the truth. Okay, any other barriers other than tough? Do you need them? I mean, sometimes you need administrative boss support to say, this is a priority, we need to find time, axe this, don't do that. I mean, and then you've got to go up the ladder. Yes?
I work at Equinox with a domestic violence shelter and a case manager, and one of our barriers, you guys mentioned how sometimes it can take someone 6 months to a year to come out with their status to you. We only have 3 months out of the domestic violence shelter. So you have to kind of get in there and, get what you need so you can put them on the list for housing.
So short-term exposure. When they come back, if they come back to you, can you ask them count the already?
I mean, if they come back to us, there's, a very high turnover rate. It's not guaranteed that the same person who worked the last time you were there is going to be there.
I mean, maybe flag it on the file next time they come back. You never really feel comfortable. We've got the story here. Okay, otherwise they're going to run out of time. So, what are your, I mean, these are issues I don't think there's easy answers. Do you report abuse? What about patients that you know their father abused them, they're probably abusing because that's the family norm. Very difficult to, you get a bad sense about some people. They maybe behave acting out what's been done to them because that's normal. How do you deal with that? I mean, I'm always very careful, whatever I put in the medical chart, I'll document how I talk to them about the importance of not asseverating bad behaviors and just leave it at that, because I don't want to end up in court. I don't know how the rest of you deal with that, but it's tricky. What about reporting abuse?
Yeah.
Yep. Do you have a legal liability too? Yeah. And what's the definition for abuse there?
Physical harm to self or anybody else, place yourself or a child, or blowing up or something. Not verbatim.
So I mean, maybe as you develop your program, you need to figure out how these are the systems. If you find something that meets your state's legal liability, how you report it. Be careful about asking about abuser, but certainly if someone was abused, getting them into treatment may impact secondary disseminate spread to next generation. And that's actually maybe a good intervention. You've got to teach them that they were abused, that doesn't mean they abuse other people, because that's not good. And you probably need to figure out how you're going to keep your records so that, I'm not sure, we're electronic, which is great because I can find out if the question's being asked. I hate dealing with paper records, and I never find where people ask. And another little thing is an irritation to me, patients who keep moving care providers. It's a nightmare. I wrote a great paper on that I love. 70% of my patients, people who leave my program, the docs look after them and never ask for our case records. Like, come on! Because they're the great doc, they can tell everything by history and looking at their lab results from today. But that's another thing. Okay, so what do you need to move this forward? I think what we heard is you're going to have a small group look at screening. Certainly you need to look at existing systems in place for people to refer to. You need to I think you need some numbers. Payers, employers are always impressed when you say 33% of my patients have experienced IPV using this definition. That's really helpful rather than, yeah, we've got a lot of this, we've got a lot of that. It will be helpful to sort of generate some numbers. It just makes people realize it's important. And, I and others, and I think you could certainly work for to show why it's important from the point of view of people dropping out of care, people losing their jobs, people having mental health resources, getting into jail, those sort of issues. So, It's important, both IPV and HIV and housing are important because there's a syndemic circle that each makes each other's worse. If you can take out one or two, you may break that circle that's syndemic. And HIV, we talked about, can improve patients' health, it can give them better self-esteem, it can remove their stigma because they're not infectious, they're insurable, they've got a future. You get their housing fixed, and they're less likely to run into domestic violence or poor adherence. If you fix the domestic violence, it may make their housing more stable, which makes their adherence better. So all of these are in this syndemic circle. If you take out one, that's good, but if you take out several, that may help the other. And then as a final for this session, I keep getting back to the root cause of my guy who was the alcoholic. And my lady, it all started when they were abused as a kid, and actually addressing the people thinking about, well, this all started from one issue. It's not they're complex because they are complex now, but it all came from a single trigger. And I think that's something important to remember. Anyway, I've overrun my 10 minutes, but it's time for lunch. Denise, do you want to?
Just let me know. Yeah, great. So lunch is set up in the other room.